Hello everyone, this is Andy Brokenbrough presenting a monthly in-service for the Northwest Kidney Center. This month's topic is dialysis access cannulation, and it was suggested by Jen at the Kent unit, and I really appreciate that. So just as a reminder, if any of you have any topics that you want me to discuss, feel free to just flag me down and request it, and there's a good chance we'll cover it. So what do I want you to get from this talk? Well, there are three objectives. One, I want you to be familiar with access history. Two, I want you to understand the different methods for vascular access cannulation, specifically rope bladder, buttonhole, and area puncture cannulation, and be familiar with the potential complications of inserting a needle into a dialysis fistula. It turns out that Seattle has a prominent part in dialysis access history, so I think it's important to be familiar with it. So in 1960, temporary or acute dialysis could be performed in limited circumstances for people with kidney failure, although typically only one or two sessions could be performed because there was no such thing at that point as chronic dialysis access, such as an arteriovenous fistula. The choice for the physician was to cut down on peripheral vessels each dialysis and then essentially tie them off after each dialysis session. Alternatively, a larger femoral blood vessel could be used could be cannulated with something called a Sheldon catheter, which is basically a precursor to today's tunneled catheter. But they were particularly prone to infections and embolic complications and clots, and so prolonged use at that point was not possible. So basically, long-term or chronic dialysis was not available at that time for patients with irreversible kidney failure. In 1960, a nephrologist at the University of Washington named Belding Scribner changed all of that. This is a year in which he developed a U-shaped tube shunt in collaboration with Wayne Quinton, who is a biomedical instrument builder at the University of Washington. And the shunt was designed so that it could be essentially left in place. So it was a semi-permanently installed between an artery and a vein in the arm so that you could keep it in place in between dialysis sessions and therefore do dialysis more than once without further traumatization of the blood vessel. So Scribner recognized that having a continuous dialysis access in a patient's bloodstream would allow for dialysis on a chronic basis. The Scribner shunt was made of a new material called Teflon, which was recommended to Scribner by one of his colleagues at the University of Washington, and chosen because the surface of Teflon was so smooth that it was less prone to clotting. The ends of this tube were inserted into an artery and into a vein, and then the blood continuously flowed through them in a shunt that was externalized. So in this picture, the shunt is present in a leg, but most often it was put in the arm. In this way, the connection between the two tubes could just be unscrewed and directly attached to the dialysis line so that no cannulation of this shunt was needed. The Scribner shunt was first implanted in the arm of a man named Clyde Shields. He was a Boeing machinist, and it was placed on March 9th, 1960. Shields became the first chronic dialysis patient. He survived an amazing 11 years on dialysis, and he died of a heart attack in 1971. With the invention of the Scribner shunt came the birth of chronic dialysis. And the Scribner shunt was the gold standard until 1966, when the first arteriovenous fistula was invented by two surgeons at the Bronx Veterans Administration Hospital. Their names were Cimino and Brescia, and that's why the formal name for a dialysis fistula is the Cimino-Brescia fistula. As you all know, an arteriovenous fistula is a surgical connection between an artery and a vein. Over time, the artery shunts high-pressured blood into the vein, and the vein develops characteristics similar to that of an artery. It's a maturation process that we call arterialization, in which basically their structural and functional remodeling of the venous wall is facilitated by various hormones. And the upshot is that over time it becomes mature and allows for repetitive needle sticks and provides a high blood flow rate to sustain dialysis. As an aside, when is a dialysis fistula ready for cannulation? It's good to remember the rule of 6, which is elucidated in the KDOQI guideline for dialysis of the Kidney Dialysis Outcome Quality Initiative. Basically, in general, you can use it about 6 weeks after creation. The blood flow should be at least 600, the diameter should be at least 6 millimeters, and the depth should be 6 millimeters or less from the surface of the skin, and the length should be about 6 centimeters for cannulation. So the Seminobrescia fistula replaced the Scribner shunt as a gold standard for dialysis access. And this meant that repeated cannulation of the vein was needed to perform dialysis. And today, this represents one of the major responsibilities of dialysis technicians and nurses. All right, let's talk a little bit about the approach to cannulating an arteriovenous fistula or graft. So how exactly should cannulation be performed? Well, there are a lot of variables to consider. For example, where to place the needles, the direction of needle placement. Should it be with blood flow, against blood flow, the orientation of the bevel, adjustment following flashback, among others. There are 3 techniques for needle insertion. One is known as a rope ladder cannulation. The other is buttonhole cannulation, which can be done with sharp or blunt needles. And the final is something called area cannulation. Rope ladder cannulation is demonstrated on the left, area cannulation in the middle, and buttonhole cannulation on the right. In the rope ladder cannulation technique, 2 new sites are chosen for needle insertion in each hemodialysis session. Ideally, the needle should be placed 5 to 7 centimeters apart. That is, the needle tips should be 5 to 7 centimeters apart and 4 centimeters from the arteriovenous anastomosis. Now, there are situations in which this is just not possible, especially if the length of the vascular access is limited or the vein becomes very deep along its route. Ideally, the vein length for puncture should be at least 10 centimeters to ensure the rotation and the distance between needles, and that results in a greater success rate with minimal complications. Rope ladder cannulation is most often indicated of the 3 techniques because it uses the entire extension of the blood vessel. There are several advantages. There's less chance for thrombosis or stenosis, infections, as well as the potential to develop aneurysms. Downside is it really requires an extensive surface for introduction of the needles. Rope ladder cannulation can be problematic for patients with short fistula lengths, tortuous blood vessels, and those who already have aneurysms. Some nephrologists prefer something called the buttonhole technique of AV fistula cannulation. It's also known as constant site cannulation. So as a reminder, a buttonhole is a hole in fabric which allows buttons to pass through, securing one piece of fabric to another, and the button is passed every time through exactly the same hole, and that's basically how needle placement is done. So buttonhole cannulation or constant site cannulation involves insertion of the needle through the same hole at the same angle every time. This allows for the creation of a cannulation tract through which a dull or a blunt needle can eventually be placed. And it's been proposed that this technique is less painful for the patient and that it's less likely to form aneurysms or stenoses or narrowings that might limit the lifespan of the fistula. It's generally associated, however, with an increase in fission risk that we'll talk about momentarily. And as an aside, it's not appropriate for arteriovenous graft cannulation as the graft material cannot withstand repeated puncture at exactly the same site. How exactly is the buttonhole cannulation technique done? So first, of course, we sanitize as we do with all access, and then you establish a track, and it generally takes 8 to 10 cannulations, so 8 to 10 dialysis sessions. You need to have the same staff person doing the cannulation until the track is established. If that same person is not available that run, use a sharp needle in a different spot, and then we change to blunt needles once the hole is defined, looks well healed, and there is minimal resistance to needle placement. So here's a picture of a tract that has been established extending down into the dialysis fistula. For several years, it was widely held by nephrologists that the buttonhole approach to cannulation was superior to, say, rope bladder cannulation. It was thought to be associated with less pain with needle insertion. There were fewer infiltrations because, again, you're using a dull needle associated with less trauma and therefore a lower risk of an infiltration or a hematoma. You had the potential to develop fewer aneurysms because, again, you're only poking through the same side, same spot over the dialysis fistula and not over many different spots, which can weaken the wall of the blood vessel, producing an aneurysm. Easier to cannulate because there's a tract already established, and it was thought that it would probably prolong the life of the fistula. But unfortunately, there is a dark side to buttonhole cannulation. It's generally associated with a 2 to 3-fold higher risk of infection because, again, you're cannulating through a potentially infected wound. It's never allowed to heal in between dialysis sessions. You're always opening up again. Locke published a study in 2014 looking at the risk of infection associated with buttonhole cannulation. It was a prospective cohort study of 630 dialysis patients in Toronto, Canada between 2001 and 2010, all of whom used a fistula for dialysis. And these patients dialyzed either in-center or at home. And if they were at home, they either did short daily dialysis or they did nocturnal dialysis. In-center patients all use rope bladder cannulations, whereas at home patients, self-cannulation was performed and some of them used the buttonhole technique. So this graph here shows the distribution of the different cannulation types among those in center and those at home. So in center, everyone used rope bladder cannulation. At home, it was about 50-50 for buttonhole use versus rope bladder cannulation. The study then looked at the rates of infection stratified by cannulation type. Among those who used rope bladder, if you dialyzed in center, there was one possible fistula infection. And among those who dialyzed at home using the rope bladder technique, there were no fistula-related infections. However, among those who used the buttonhole technique, there were 39 cases of bacteremia, 85% of which were Staph aureus, and there were at least 2 local buttonhole site infections. 13% of the patients were hospitalized with infections related to the buttonhole, and 10% had serious metastatic infections associated with their bacteremia. This table basically summarizes the information I just passed on. There were basically no infections or only one questionable infection among those who used rope bladder technique, and there were a lot of infections among those who used buttonhole technique. In conclusion, buttonhole technique is associated with a significantly higher rate of infection. It's the technique itself. It is not the frequency of cannulation, because among those who did daily home dialysis, with the rope bladder technique, there were no infections. It has nothing to do with whether or not a dialysis nurse or the patient did their own cannulation, and it had nothing to do with the location, either in center or home. It could all be explained by the use of the buttonhole technique. The third technique for introducing needles into a fistula is called area puncture. This approach involves cannulating the same general area, but not necessarily the same point as in buttonhole technique, session after session. There is no definition of a minimum distance from the previous puncture to consider the cannulation as being area versus rope bladder technique. And the lack of criteria does cause some confusion, but in general, if you're inserting a needle less than 2 centimeters from the previous cannulation, then that technique should be considered area puncture. The advantage of the area puncture technique is that if you keep poking the same spot, you destroy all the nerve fibers in that area, and that results in decreased pain during cannulation. But there's some significant disadvantages. If you keep poking the same general area, you weaken the wall in multiple points, and that predisposes to stretching the wall or aneurysm formation. You can also get pseudoaneurysms at higher rates, stenosis or narrowing of the fistula, blood clots or thrombosis, and infections, particularly if you're using an AV graft. And that's why both the American and European dialysis guidelines say that area puncture should not be used because of the increased risk of complication rates. Unfortunately, I think area puncture is what happens in most dialysis units around the country. This represents an opportunity for improvement. Okay, let's talk about some general guidelines regarding needle insertion. It's very important to place needles as far apart as possible to avoid something called access recirculation. Access recirculation occurs when clean blood from the venous needle gets sucked up by the arterial needle rather than returned to the systemic circulation. So by dialyzing the same blood over and over, fewer waste products are removed from the blood and the efficiency or so-called adequacy of dialysis becomes reduced. And it's probable that close proximity of needles or misdirection of the arteriovenous needles is probably the most common cause of access recirculation. And this is particularly true of loop grafts. If you misplace the arteriovenous needles, i.e. switch their orientation, then recirculation will definitely occur. One study published by Bellotti in 2010 was a cross-sectional study of 100 dialysis patients with AV fistulas who were on dialysis for more than 3 months, undergoing two-needle technique method of dialysis, and they found that misdirection of needles was the most common cause of AV fistula recirculation at their center. Another study published by Diaz reported that a distance between the needle tips greater than 5 centimeters is associated with less blood recirculation and greater dialysis delivery. Now, in order to get the needle tips apart by more than 5 centimeters, it often requires needles to be placed in opposite directions. If the needles are both placed in the direction of the blood flow, which is what we generally do, that is called antegrade needle placement. On the other hand, if you place a needle in the opposite direction of blood flow, that's called retrograde. So the venous needle always has to be antegrade, but the arterial needle can be retrograde, and this is a good technique for separating the needle tips. Now, if you have a dialysis patient whose dialysis adequacy is constantly below target, consider placing the needles in opposite directions to ensure maximal separation in distance of the needle tips. Regarding needle size, 17 gauge needles are the most often used for new fistulas, and as the AV fistula matures and often grows in size, the needle size can be advanced to 16 gauge and 15 and sometimes even 14 gauge needles, depending on the blood flow that's desired. The higher the blood flow, the greater the caliber of needle that's required. So typically for a blood flow less than 300, we use 17 gauge needles. If it's 300 to 350, we use 16. And if it's above 350, we generally use 15 gauge needles. Higher gauge allows for greater blood flow, and that improves dialysis efficiency or adequacy. Okay, just a few technical points. This is a really important point. I really want you to remember it from this talk. After you sterilize the skin, prior to insertion of the needles, be careful not to touch the sterilized field with your glove. The glove is not sterile, and this is a really common mistake and increases the risk for access infection. If you touch it with the glove, you've contaminated the field and there could be bacteria there. Regarding the AV fistula cannulation, KDOQI, again, the Kidney Dialysis Outcome Quality Initiative, which is sort of an advisory board for dialysis that passes guidelines, recommends puncturing the angle at 25 degrees with the bevel up. And then similarly, you need to withdraw the needle at the same angle used for puncture, and you apply pressure only to the vessel after completely removing of the needles. For grafts, KDOQI recommends 45-degree angle of puncture and no needle rotation within the graft. Sometimes needle placement is very difficult, and ultrasound can be a useful tool for cannulation. Ultrasound-guided needle placement provides real-time visual feedback and can help improve the accuracy of needle placement. You can actually see the needle penetrate the blood vessel, and therefore it has the potential to minimize AV fistula damage, and that, of course, is good for the fistula in the long run. As an aside, it's important not to contaminate the sterile field with the gel or the probe. Now, some experienced operators can perform the procedure without exposing the skin entry site to ultrasound gel. So the use of sterilized ultrasound gel, it's not always necessary. Sometimes you can just put on some sterile saline onto the field, and that is enough of a medium to allow for an ultrasound image to be generated. There are some potential complications if needle placement does not go well. The four main categories of complications include thrombosis or clotting, hemorrhage or bleeding, infection, and the formation of aneurysms. Aneurysms are a dilation of the blood vessel wall. They can be formed by repeated needle punctures in a centralized area, and that can weaken the access wall and again lead to dilation of the wall or aneurysm formation. Aneurysm dilatation can also occur over time just due to high blood flow rate, and that can be accelerated by high pressures within the fistula, say if you have a stenosis or a narrowing. Aneurysms generally require surgical repair if there's loss of skin integrity, like the skin starts to break down, and certainly if there's an ulcer, and high risk aneurysms, if left untreated, can rupture and patients can die of acute blood loss. In contrast to an aneurysm, a pseudoaneurysm is a false aneurysm. So it's not a dilation of the blood vessel wall. What it is a hole in the wall through which the blood can leak. So it occurs when a blood vessel wall or the graft is injured. Say if you poke a big dialysis needle into it and the blood gets contained by the surrounding tissues. So it's not a true aneurysm which is surrounded by a wall of the blood vessel. It is a false aneurysm or a pseudoaneurysm where the blood is contained by the tissue. It is more common with grafts than fistulas. Infection is another potential complication, particularly if the skin is not sterilized properly or if the sterile field gets contaminated, again, say with a glove or with an ultrasound probe. So most dialysis fistulas involve what we call perivascular cellulitis. So around the blood vessel there is inflammation of the soft tissue and skin. We call that cellulitis, and that presents with redness, swelling, warmth, basically focal signs of infection. Patients can have fever as well, so there can be systemic signs. Localized infections can be treated with antibiotics, but more serious infections can sometimes develop into an abscess, and that can require surgical excision and sometimes surgical drainage and sometimes even excision. Remember, after sterilizing the skin prior to cannulation, be careful not to touch a sterilized field with your glove. The glove is not sterile. That is a common mistake and increases the risk for access infection. Okay, time to summarize what we've learned. There was no chronic dialysis before Belding, Scribner, a nephrologist at the University of Washington here in Seattle, developed the first dialysis access, or the Scribner shunt. And there was no cannulation of access required until James Cimino and M.J. Brescia at the Bronx Veterans Administration Hospital created the first dialysis arteriovenous fistula in 1966. There are three methods for vascular access cannulation: rope bladder, area puncture, and buttonhole. Rope bladder techniques is preferred because it uses the entire extension of the vessel. It's associated with less clotting, less narrowing, fewer infections, fewer potentials for aneurysm, at least compared with area puncture. Buttonhole cannulation, also known as constant site cannulation, involves insertion of the needle through the same hole at the same angle every time. In theory, it may reduce pain with needle insertion and may be associated with less aneurysm formation, but there is a 2 to 3-fold higher risk of infection. Finally, area puncture is something we should not do. It involves cannulating the same general area, but not necessarily the same point session after session. Should not be used because of the risk of complications such as aneurysms and hemorrhage. Ideally, needle tips should be separated by at least 5 centimeters to reduce the risk of recirculation. Recirculation again occurs when clean blood from the venous needle gets sucked up by the arterial needle rather than return to the systemic circulation. So you're cleaning the same blood over and over, and this reduces the efficiency or the adequacy of dialysis. If you have a patient who has, low KT over V or low adequacy and you're concerned about recirculation, consider placing the arterial needle retrograde. So in other words, opposite direction of the venous needle to improve adequacy. It just makes it less likely that the venous blood will get separated or get sucked up by the arterial needle because of the greater distance and separation of the tips. Ultrasound is a useful tool for accessing fistulas that are deep or difficult to cannulate. Major complications of access placement include aneurysm, pseudoaneurysm, and infection. Okay, time to see if you are paying attention. Question number 1, who invented the first chronic dialysis access? Question number 2, for a standard fistula of length greater than 10 centimeters, what is the preferred cannulation method? That's right, the rope ladder cannulation. Question number 3, which approach to access cannulation is associated with the highest risk of infection? Excellent, the buttonhole technique. Question number 4, what approach to access cannulation is associated with the highest risk of aneurysm formation? That's right, area puncture. So this is what we should not do. We should not poke really close to where the needles were placed the previous dialysis session. How far apart should needle tips be placed and why? That's right, so more than 5 centimeters ideally to minimize the risk of recirculation. Final question, this technology is useful in patients with fistulae that are deep or otherwise hard to cannulate. Excellent. What is ultrasound technology? This includes the May 2024 in-service for the Northwest Kidney Center. Thank you to Jen for suggesting the topic. Again, happy to accept any suggestions for future topics, and thank you for everything you guys do for our patients. This is Andy Brokenborough signing out. Until next month.